Welcome to Child and Adolescent Psychiatry Grand Rounds. I'm Dr. Suzanne Squires. I'm a family doctor who works in Spruce Grove at West Grove Clinic, and I'm also the board chair of the Westview Primary Care Network. And I also am with CanReach, with Teaching CanReach, and that's how I found myself on the Child and Adolescent Psychiatry Grand Rounds Steering Committee. I know most of you are used to seeing Dr. Alice Leung chair these, but she's away, and I'm happy to step in. I'm also very grateful to the FOMD Office of Lifelong Learning, who provides the logistical and technical support for these rounds. And I'm very excited about today's topic. This is something that I know is applicable to my practice, and I often feel a little lost, and so do my patients, knowing where to start, what treatments can be done. So I'm anticipating a great talk this morning. I'd like to start with our land acknowledgement. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Nehiyawh Cree, Niitsitapi, Blackfoot, Métis, Nakota, Stoney, Dene, Haudenosaunee, Iroquois, and Anishinaabe, Ojibwe Saulteaux lands that are now known as part of the Treaties 6, 7, and 8, and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. Just a few housekeeping notes. Just use the chat feature if you have a question about technical difficulties or any of the L-Theory programs and services. We do have support that can answer your questions. If you have a question for the speaker, use the Q&A feature of the webinar. Our plan today is we need to be done within an hour. This needs to wrap up by 11:30. So Dr. Richer is going to present for about 45 minutes, and then we're going to open it up to question and answer for the last 15 minutes. When you're looking at the questions, review what's already been asked and upvote those questions that you'd like to be answered. And then I'll help us moderate a question and answer at the end of the presentation. Unfortunately, we can't guarantee that the panelist is going to answer all of your questions, but we're going to do our best, and hopefully we get through them. So without further ado, I'm going to present Dr. Lawrence Richer. He's a clinical epidemiologist and a professor in the Department of Pediatrics at the University of Alberta, and he's a practicing pediatric neurologist here in our community. He serves as the Associate Dean of Research for the College of Health Sciences and the Center Director of the Northern Alberta Clinical Trials and Research Center. In his leadership roles, he's committed to advancing support for impactful interdisciplinary health research, clinical trials, and leveraging health data to improve patient outcomes. His research focuses on developing a better understanding of the mechanisms and management of the myriad of conditions that include orthostatic intolerance in children, such as postural orthostatic tachycardic syndrome, also known as POTS, concussion, long COVID, and chronic migraine. Welcome, Dr. Richer.
Thank you for having me, and thanks for that kind introduction. I'll share my screen here. So hopefully at the end of this, I haven't made you all dizzy, but the issues that you are hearing from your patients in clinic, I think, is certainly something that I have had the privilege in many ways of serving patients with these conditions. And, it's sort of led me to my research interests, why are these persons reporting the same problem over and over again across these conditions. So I'm gonna do something a little differently. Often a POTS talk is presented by cardiologists and they forget that the brain's involved. And then the chronic migraineurs, chronic migraine talks talk about headache as if, there's nothing else going on in the person's life or their body. But I'm going to try to bring some of that together. And I'm going to just, take you a little bit down the road of some of my thoughts about how these things might be connected in some ways. So my learning objectives are to review with you orthostatic dizziness as a symptom, something that it's actually worth asking about in many conditions, and some of the potential origins of that as a symptom. Of course, there are some conditions where we hear about the symptom far more commonly, and that is POTS and more recently long COVID. And I, in most of my practice for the last 20 plus years, have been very focused on headache and chronic migraine. Quite often, if you ask the question, what happens to you when you stand up in the morning? I'm less surprised now, but it's certainly remarkable how often that answer leads us down a different path. And so, I want to explore some of the common physiologic pathways that might underlie orthostatic intolerance, if it's such a common symptom and seems to be in the context of those with other comorbidities and reported difficulties. What is this? And then finally, I'm going to spend some time on management. So hopefully there will be some takeaways that are useful to you in your practices. This is my anchor patient, Maya Stock. This is presented with permission, of course. She told her story to me many years ago, and now through the Be the Cure campaign, has this story up on the Be the Cure website. And she talks about their experience where she had a bunch of symptoms like dizziness, fatigue, chest pain, and fast heart rate. Those were her sort of core presenting symptoms, that kind of stuff, as she says. But my worst symptoms were fatigue and dizziness, and that's a very common statement that I'll bring you back to. Every time you stood up, you either fainted or felt like you were going to, and you just had no energy and constant headaches and migraines. So this is really my anchor patient. What is going on with this otherwise previously well person who may have had some past history of minor head injuries, minor concussions, but otherwise a very healthy, active dancer, and what happened to her, and what is going on? When she presented, she was stuck in her bed, and now she found ways to actually live her life. And so that's my anchor patient. And I'm going to just take a little bit of time on some physiology, and just to remind everybody how important so many mechanisms are to simply maintaining an upright posture. A lot of things need to happen quickly, and hopefully you can see my cursor here. Can you let me know, Suzanne, can you see my cursor?
Yes,
we can see it.
Okay, great. So I won't assume otherwise. When standing, there's this shift. It's been estimated to be about a shift of 0.5 liter of blood to our lower extremities. And in that first 30 seconds upon standing, a lot of things happen to adjust for that shift of blood to the lower extremities. There are central mechanisms involving the vestibular and proprioceptive systems, as well as visual systems. The one we know well and have studied the most is the baroreceptors in the carotid sinus, as well as the mechanoreceptors in the aortic arch that sense this sudden drop in blood pressure, as well as reduced preload or reduced venous return. And then, but let's not forget that there are other mechanisms as well. I mean, the arterial systems peripherally will contribute to systemic vascular resistance, but also contribute to this notion of pooling, whether it be in the lower extremity, the splanchnic space, the pelvic space, or other cutaneous redistribution, such as, if you're just stepping out of a hot tub, for example, what's going to happen to you? Well, you've got a lot more blood in your skin. And so that postural change will be that much more pronounced or after a heavy meal. I'm going to talk a little bit about muscles. We sometimes don't, I think, pay enough attention to what's going on our muscles and how these so-called ergoreceptors, which are both mechano and metabolic receptors in the muscle, contribute greatly to modifying our responses to being upright and moving. And then finally, our venous system is so important in the venous hemodynamics. And so it's just meant to be a cartoon to reflect the myriad of things that have to go right so we don't pass out when we stand up. And that all happens within the first 30 seconds. And I can show you on the average tilt table test how quickly and consistently that happens. But there's also, of course, a lot happening centrally. And when we think about the brain and its importance to what we want to do, maintaining cerebral blood flow across a range of blood pressures is a critically important, evolutionarily important concept. And so some of my research focus has started to ask the question, well, what's different about how cerebral blood flow is maintained in persons who talk about feeling dizzy all the time? Is it a problem of cerebral autoregulation? And I'll speak more about that. Is a problem about cerebrovascular reactivity, those very rapid changes that occur particularly in response to carbon dioxide, which the intensivists use all the time in the ICU to manipulate intracranial pressure. Is it the neurovascular unit? That whole notion that as we think, as we go through life, the brain is constantly adapting and shifting regional blood flow in ways to ensure that the energy required to maintain those cognitive activities can occur. There's the endothelium at the level of the small blood vessels. There's hypothalamic and pituitary influences with the renin-angiotensin system. And of course, all the integrative mechanisms of the hypothalamus to external stimuli, whether it be stress or heat or otherwise. And then not to forget, of course, the baroreceptor and how much about critical importance that plays in maintaining that. And then all of that is actualized, much of that is actualized through what we call the peripheral autonomic nervous system, sympathetic and parasympathetic. But again, this is meant to illustrate how important many mechanisms, or how many mechanisms come to play and must function in a coordinated way to maintain upright posture and have people not feel dizzy and lightheaded when they stand up. So just a quick reminder about cerebral blood flow. The brain is a very demanding organ. 20% of oxygen and glucose supply goes to the brain. And there's this very classic Lasson's curve, which is depicted here, that is said to, it is hypothesized in this case. This is the amalgamation of multiple studies that showed that between a range of blood pressures, the brain has a way of ensuring that cerebral perfusion pressure is maintained, or cerebral blood flow is maintained. So if we think of cerebral blood flow in the form of a formula, it is the maintenance of cerebral perfusion pressure, as well as in the context of cerebrovascular resistance. So, and cerebral perfusion pressure is a measure of our arterial pressure minus our ICP, and so many things go into ICP. So I show this formula because it starts to show why typically when I was taught about cerebral blood flow, it was taught from the perspective of a person lying in an ICU bed or a person lying on a surgical bed under anesthesia. That is to say, in a static way. But what we're asking is, how does cerebral blood flow change with postural change? And there are many other things that come into play. Number one is cerebrovascular resistance. So there's both intracranial and extracranial contributions to that resistance. And as resistance goes up, cerebral blood flow will go down. But there are also ICP shifts that aren't accounted for typically under those static environments, such as gravity-induced gradients, or CSF shifts to the dural space, as well as venous pressure. So again, many contributions to cerebral blood flow. Also, it's important to recognize that the Lasson's curve and that concept of cerebral autoregulation is more of a static response. It responds more to long-term changes in blood pressure. So someone with hypertension or hypotension will have some adjustment in cerebral autoregulation in response to that longer-term context. But very rapid changes still cause a direct reflection on cerebral blood flow. So this is a person doing a squat stand test where blood pressure goes up and down, up and down. And as you can see, it's directly mirrored with cerebral blood flow. And so that many of these very rapid adjustments or rapid changes in blood pressure are directly reflected on the brain. And so the Lasson's curve doesn't apply in that very immediate short-term scenario. So again, just to reiterate the number of mechanisms that go into regulating cerebral blood flow, from autoregulation, and cerebral vascular reactivity, the neurovascular coupling, and the endothelium. And then finally, a lot that we don't know, such as how does behavior, posture, genetics, temperature, and other vascular factors play into this? And so there's a lot we don't know in this space as well. Just to emphasize the complexity of all of this is we often think of the blood vessel as one thing, but there's a significant heterogeneity, whether you're talking about larger vessels or the smaller arteries and arterioles, or whether it is the capillaries. And this is just to illustrate how in this case, this is a single cell RNA sequencing can show that I'm showing here, and how much variation in the genetic makeup and the genetic and the RNA sequencing, that the RNA output of the genetic code that varies between the different types of arteries. And so there's a lot of coordination required simply in the cerebral arteries, and whether you're talking about the large vessels or the smaller arteries with smooth muscle, or the smaller arterioles and capillaries without any smooth muscle. So a very anxious person who has, driven their sympathetic nervous system up may have reduced cerebral blood flow because of the sympathetic innervation of the large arteries, but there'll be an adjustment down distal to that in the smooth muscle. So while it isn't sufficient to say that sympathetic activation causes decreased cerebral blood flow, because there's a compensation downstream from that in the smooth muscles dilating as a consequence to that change. And so again, simplistic answers will never be sufficient to explain cerebral blood flow and its changes in this dynamic context of postural change. And I'm a pediatrician, so I need to reiterate or emphasize that that these are changing brains. And so when we're looking at a child, or whether we're looking at an adolescent, it isn't necessarily the same. And again, the details of this table are not important, but you can see how much changes in terms of the brain and its perfusion with age. And so it in very early age and early development, it's approximately 60% of total cardiac output, or oxygen and glucose consumption, goes to the brain, as opposed to 20% as we get older. And so again, the child and adolescent context is not likely the same as the young adult or older adult context. And I'd be remiss not to acknowledge how much of this is coordinated centrally. So much of the peripheral input that goes into regulating our upright posture is concentrated in the medulla. And if you just remember one nucleus, the nucleus of the tractus solitarius, or the nucleus of the solitary tract, is a key integrative nucleus that then goes on to coordinate actions in response to mostly changes in barometric sensors. There are many, many other things that go into that. In terms of supratentorial aspects, from the prefrontal cortex down to the hypothalamus, many, many areas of coordination that respond to behavior and emotion and stress, that communicate with the pons and medulla, as well as the tegmentum, which coordinates our body's responses as it relates to arousal or pain. And then all of those responses need to be communicated to the periphery through the spinal cord. And there are many segmental reflexes that coordinate these activities as well, such as whether we are constipated or whether we need to go to the bathroom, for example. So again, just to highlight the highly integrated nature of the autonomic nervous system generally, and how many things go into maintaining a degree of homeostasis, whether we're lying or standing. And then just as a concept, it starts to make sense to me, at least, and hopefully to you, how relatively complex constructs of major life events, trauma, or abuse can lead to a dysfunction of this whole system. And we talk about allostatic load as a concept of the wear and tear on our normal physiologic mechanisms and behavioral mechanisms to adapt, to change. And so allostasis being the combination of physiological and behavioral responses in response to threat or stress or some change in our base environment. And that over time, if we are we are exposed to those on frequent basis, or very prolonged exposures to these things, that we develop a maladaptive response, or through wear and tear on our normal physiologic responses, a maladaptive response becomes the norm. And I think that concept of allostatic load is of growing interest in the chronic pain, chronic migraine space, and I think deserves some attention in this space as well. So that's and oh, sorry, this is my last slide on physiology. I want to just bring us back to the muscle and its importance in regulating our heart responses to both exercise as well as posture. And there are both mechanical receptors in the muscle as well as metabolic receptors in the muscle that respond to many changes, such as lactic acid, but as well as stretch as well, that then lead to changes through central integration, likely through the nucleus tractus solitarius. You see it there, which lead to changes in ventilation, changes in peripheral resistance, as well as increase in heart rate and contractility. So I think this is the muscle's contribution to what's going on in many of these patients is understudied. But when we look at POTS and how often we refer persons with POTS to exercise as an intervention, maybe some of this starts to make more sense. So postural orthostatic tachycardia syndrome. Essentially, in a nutshell, POTS patients feel awful when upright. And we can neatly divide them between cardiac and CNS symptoms, but exercise intolerance, in terms of symptoms that bother patients, exercise intolerance is one of the most commonly reported, as well as in the CNS, fatigue, brain fog, and then this whole concept of dizziness, which is a poorly defined symptom, but frequently reported. And then we see headache, anxiety, sleep difficulties, as well as air hunger, chest discomfort, and palpitations. So what is this? Well, this is, we made an effort to sort of understand orthostatic tachycardia generally. What are the conditions that lead to a significant increase in heart rate without a significant decrease in blood pressure, which is the definition of postural orthostatic tachycardia? And then what are the other conditions which are similar to, but not necessarily manifesting all of those? And so a group of us published in the Canadian Cardiac Society a statement on orthostatic intolerance, and this is one of the graphs that we use in that statement. That all of us, to some degree, may have some degree of orthostatic tachycardia on standing, and may report brief or intermittent symptoms. But as those symptoms become chronic and persistent, or as that tachycardia becomes more manifest, that is what we talk about in terms of POTS. We propose the concept of POTS plus, and that I'll show you a slide later, that whole notion that POTS has many comorbidities. And then also the observation that some persons with postural tachycardia don't report symptoms, what's going on in them. And then another group report postural tachycardia of other causes. And this is the classic manifestation of POTS, that is a significant increase in heart rate with the elevated position. So this is the tilt table to 70 degrees with no real change in blood pressure. And compare that to the typical vasodepressor syncope or vasovasal syncope, where there may be some change in heart rate, but it isn't dramatic. But at the end of the procedure, there's this dramatic fall, or in a positive procedure, we don't always see this. At the end of the test, we see this dramatic fall in heart rate, dramatic fall in blood pressure, which leads to syncope, and then an immediate return to consciousness and stabilization of their parameters when they're returned to the supine position. So that's orthostatic tachycardia in a nutshell. And we start to divide POTS into different types. And we talk about three main types, being neuropathic, hypovolemic, and hyperadrenergic. And I think it is important from a treatment perspective to understand these differences. Neuropathic POTS is thought to be a partial autonomic neuropathy. Hypovolemic POTS is, for various reasons, many persons have a degree of hypovolemia, and then hyperadrenergic POTS, those with baseline elevated adrenergic activation. And the end result is, for each of these, is an increase in sympathetic nerve activity, and that can be measured in norepinephrine spillover and other measures of a baseline sympathetic activity, which all lead to tachycardia and the various symptoms that we observe. This is a more busy demonstration of these types in an effort to make some sense of it. POTS is defined as a heterogeneous syndrome without one symptom, but many chronic symptoms. But at the base, they report orthostatic intolerance with significant orthostatic tachycardia. That is the definition. 30 beats per minute, greater than 30 beats per minute change in adults, greater than 40 beats per minute change in adolescents. And then the three main types being hyperadrenergic, volume dysregulation, and small fiber nerve dysfunction. A commonly a growing area of interest in this whole area is that of autoimmune mechanisms, which may cause any one of these three types, as well as the important contribution of prolonged bed rest and deconditioning. And a slide later, I think, does a better job at depicting what this, how this may be contributing. But if someone goes on to develop symptoms of POTS for whatever reason, the worse they feel, the less they do, and the less they do, the worse they feel. And there's no good understanding at what point does what was their original symptom become no longer the problem, or what was their original cause, I should say, is no longer the problem, but their response to that initial symptom is now the problem. So that the fact that because they haven't been feeling well, they are now deconditioned, and now they have symptoms of deconditioning, but the original event is gone. We don't really have any way of understanding. There's no consensus on this at all to understand where one stops and the other begins. POTS has many coexisting conditions, and these are most of them, I would say, that at least that I see in my practice. Concussion and migraine are the two that I have seen the most often contributing to POTS. And, you know, I might have started following a patient with migraine and then later discover that orthostatic intolerance is a major symptom of theirs. Often concussion is an inciting event. Mast cell activation is another area of, not my area of specialty, but certainly I become involved in caring for patients who have this. Functional GI disorders, joint hypermobility and Ehlers-Danlos syndrome, and then this important area to acknowledge, this notion of autoimmunity. And I say that because, at least at the practice that I have, when they're coming to see me, it's often to explore the possibility that we need to treat autoimmunity as the underlying cause for their intractable POTS symptoms. So I'm going to likely, just looking at the time I have, I do research in this space, and I wanted to just highlight a little bit about that. But I'm going to probably move fairly quickly through these. But suffice to say that cerebral blood flow with orthostatic stress is different in persons who report symptoms of orthostatic dizziness. So healthy volunteers, when measured, have very small changes in cerebral blood flow with head-up tilt. And this has been shown. And so it isn't necessarily observed in those who don't report orthostatic dizziness. But we wanted to better understand what's happening in POTS patients, and cerebral blood flow as measured through the transcranial Doppler, which is a measure of the speed or velocity of flow through the middle cerebral artery, usually, is a surrogate measure of cerebral blood flow. What we were interested in is cerebral perfusion, and so we decided to do a study looking at cerebral perfusion in the brain of persons with POTS, and we simulated standing through negative lower body pressure. So we put their legs, and you can see it here, in a negative lower body chamber. We created negative pressure inside that chamber. You can see this is actually the liner of a waterbed. So we manufactured this specifically for this study. And we create a negative pressure environment, which simulates standing by sucking blood to the lower extremity, and then measured both cardiac as well as cerebral parameters. And this is just an illustration or one of the slides in our publication now that reported the changes in cerebral blood flow. And in essence, we did not observe a big change in or any regional variation in persons reporting POTS versus healthy volunteers in this small cohort of adolescents. We, however, went on to estimate some other parameters such as cerebral oxygenation using in this case, the sagittal sinus. And these are the cardiac measures. And while we were definitely inducing a change with the negative lower body pressure, there was no real difference between controls and persons with POTS in any of the parameters we measured. So stroke volume, cardiac output, cerebral blood flow in velocity, as well as cerebral oxygenation. However, we did observe some unique variation in the way oxygen was being extracted from the brain in some individuals. And this is an example of normal oxygen extraction. And this is being measured in the sagittal sinus. And we can see that with increasing cerebral blood flow, you would expect increases in oxygen saturation. And however, we saw a variation in responses between different types of POTS patients that were quite abnormal in terms of the expected results. And so, it begs the question, if POTS is a syndrome, what measures do we have to understand the differences between persons? And then as it relates to cerebral blood flow and cerebral oxygenation, is understanding those differences a way of treating them more precisely or in a more individualized fashion? So I'm going to just move a bit more rapidly through these. It's interesting, and again, does cerebral blood flow contribute to this? This is a study published some years ago now, showing how simply changing the degree of incline. So this is going from a tilt of 0 degrees to 75 degrees, causes significant changes, and more so in a group of chronic fatigue syndrome or POTS patients, in cognitive function. So the cognitive function being measured using the 0 back, 1 back, 2 back, 3 back test. It's a surrogate measure of, I would say, more attention than anything else, but being able to recall digits from 1 digit ago, 2 digits ago, or 3 digits ago. And we can see increasing poor response, but a differential response depending on whether the head of the bed was at 75 degrees or at 0 degrees, and most prominently in the chronic fatigue syndrome patients. And so reaction times went dramatically up in those with chronic fatigue syndrome or POTS. And you can see how there is a decline in cognitive function as the head of the bed goes up. So this is a very dynamic process that simply being upright, a patient will tell you, I feel dizzy, lightheaded, and I can't think. Those symptoms that they describe at school, like I can't get through the day at school, my brain's tired, I can't think, start to make a lot of physiologic sense. I'll skip that one. And then I wanted to illustrate, as I indicated in the objectives, some of the commonality between conditions. So we started talking about POTS, but look at the commonality between post-COVID condition, chronic fatigue syndrome, post-concussion syndrome, chronic migraine, and Ehlers-Danlos. All of those conditions talk about migraine and brain fog. They talk about chest pain and angina-like symptoms. They report venous pooling. They talk about heat and cold intolerance. Raynaud's phenomena or vasomotor reactivity. Many of them talk about fatigue and exercise intolerance, hypovolemia, tachycardia, as well as orthostatic, as well as postprandial symptoms. So after I eat, I feel bad, or after I stand, I feel bad. And so it begs the question, what are some of the commonalities between these conditions that we need to look at? This is a study of neurocognitive symptoms following long COVID, showing a marked correlation between cerebral blood flow, change in cerebral blood flow velocity, as well as the report of symptoms such as fatigue and cognitive impairment post-COVID. So in this setting, those with COVID-19 who went on to also have symptoms of chronic fatigue or POTS reported the greatest change in cerebral blood flow velocity. But very similarly, so did persons with chronic fatigue and POTS, and so did persons without POTS, but reporting chronic fatigue. So cerebral blood flow does seem to be an important contributor to some of these symptoms. What about brain perfusion? This is a demonstration of brain perfusion using the same technique I used in our study, arterial spin labeling in MRI, to show how post-COVID subjects reported significant cognitive impairment following SARS-CoV-2, and that impairment was associated with significant decreases in perfusion of many areas of the brain, such as the prefrontal cortex, and for whatever reason, more prominently on the right. So another demonstration that brain perfusion in other conditions, while we weren't able to show it in our small cohort of POTS patients, it is being shown in other contexts that there is a significant change in cerebral perfusion as well in long COVID. What about the blood-brain barrier and long COVID? And what is this? What do we mean by this notion of brain fog? So this is again, I showed this one to you partly to just emphasize that I'm not making this up. This is the Nature Neuroscience paper showing significant alterations of brain structure, gray matter, white matter, CSF volume, and significant immunologic changes in those who have long COVID and brain fog compared with those who do not report those symptoms. So here, showing whether you have brain fog or no brain fog, big changes in either the structure of the brain, such as the volume of white or gray matter, in different regions of the brain. So right, left, frontal cortex, left frontal cortex. And then this study also went on to show many changes in immunologic responses as well. All right, that leaves us time for diagnosis and management. So I hope I've been able to illustrate the importance of cerebral blood flow. I hope I've been able to illustrate the importance of looking at this symptom as a symptom that's shared across conditions such as POTS and long COVID. And hopefully some of that insight, is helpful in understanding our approach to management. So the approach to investigation and diagnosis in these patients, I'm not surprised by the Dr. Squire's initial comments that it can be quite difficult to understand where to go with some of these patients. And hopefully I can shed some light on that, but you'll tell me if I do or don't. The number one question that I get most often is, do I need to order testing? And so I'm going to address that one out of the gates. Most of the time, persons reporting orthostatic intolerance, that is, I develop symptoms on standing that are relieved by sitting or lying down, do not need formal testing. So if a person comes to you reporting those symptoms, number one would be to understand if there are any red flags for other cardiac syndromes or centrally mediated causes like epilepsy, in which case you would walk down a different diagnostic path. If this seems to be presenting like vasovagal syncope, that is to say, recurrent episodic symptoms of loss of consciousness, not associated with daily symptoms of dizziness and lightheadedness, that is vasovagal syndrome. And that doesn't need formal testing. You can make that clinical diagnosis of vasovagal syncope or neurally mediated syncope. However, if they are reporting chronic symptoms of orthostatic intolerance, Again, most of the time, a formal autonomic test or tilt table test is not required. A bedside test of active standing for 5 to 10 minutes would be adequate to make the diagnosis of POTS. So you ask the patient to simply rest in the supine position, get a resting heart rate, and then have them stand without fidgeting or moving for a period of 5 to 10 minutes and track their heart rate. And a sustained increase in heart rate for greater than 1 minute of greater than 30 beats per minute in adults or 40 beats per minute in children and adolescents would be sufficient for the diagnosis of POTS. However, there are some that do warrant more formal testing. And this is my list, as well as a list that has been reported by others as being reasonable. So those who are unresponsive to initial management may benefit from autonomic testing or tilt table test. Those who you suspect have orthostatic hypotension, that's probably something different, and that can reflect neurogenic causes, and so may benefit from formal testing. As well as those who you simply don't have a diagnosis for. If they lose consciousness frequently, what is that? And sometimes the formal testing can provide some insight there, whether it's a strange reflex syncope or an epileptically or ictal generated syncope, or much more commonly psychogenic or pseudosyncope. So those are the indications for tilt table test. This is what my formal autonomic testing looks like. This is the tilt table test. We look at heart rate variability, with deep breathing, as well as the Valsalva maneuver. So with the head up tilt, you see this immediate change. And this is what I talk about, how important this immediate adaptation to postural change. So this is going from 0 degrees to 70 degrees right here. And in this particular patient, there was a rapid drop in blood pressure, followed by a gradual return to a near baseline value. So not terrible, systolic of about 100 here. But you see this dramatic increase in heart rate from the mid 70s to as high as 130 over here. And so that defines orthostatic tachycardia, postural orthostatic tachycardia. That is not significant change in blood pressure, but a dramatic increase in heart rate. The deep breathing test, this is just simply breathing at 6 breaths a minute. You can see how much of a variation in heart rate that creates in a normal individual. A very abnormal test here would be a flat line. So persons with untreated diabetic neuropathy, for example, would not show any variation in heart rate in this test. And then with the Valsalva maneuver, the Valsalva creates increased intrathoracic pressure. You can see that pressure reflected here. That leads to a decrease in blood pressure due to decreased venous return. There's an adaptation to that response in heart rate and a return to baseline of blood pressure. And then when we let go of the Valsalva, it all returns to baseline. So this would be a normal Valsalva. A very abnormal test here would be a fall in blood pressure with no heart rate response, and that would be in keeping with some form of neurogenic cause. So that's what I do in the autonomic testing lab, as well as the sweat test, which I'll show you in a bit. And what you'll see in my reports and most reports is a distinction between what we observe in dysregulation, that is, in response to a low blood pressure, the heart rate went up. That's normal. We expect that. We want that. But it went up dramatically. So that's a dysregulated response versus, in this case, no response. So here's a dramatic fall in blood pressure and no real change in heart rate. And that reflects autonomic failure. So you'll see in my reports, the statement, no evidence of autonomic failure. And I say that very intentionally to say that I do not think that there's denervation of the heart. This is a depiction of how efferent failure, so outputs from the brain having degenerated would look versus inputs to the brain and baroreceptor systems. This is afferent failure. So a classic afferent failure would be Riley-Day syndrome or familial dysautonomia, where the nerves innervating the autonomic nervous system are degenerating. And in the absence of those nerves, there's no ability to respond. And so you get this lack of heart rate response, a lack of a pressor response. But in response to emotion, you can have this exaggerated response, so hypertension and tachycardia. And that would be, the classic scenario of an afferent failure. This is the classic scenario of Ethan failure, which we don't see too much in kids, but multiple system atrophy, for example, would lead to this, again, lack of a heart rate response, lack of a pressor response, but in response to emotion, also no response, because they simply can't output that adrenergic drive. And then this is the sweat response. There's the other test that we do, and this is to assess for neuropathy. Now, the test that I do is this one here called the Q-SART, or Q-SWEAT is another name for it. And what we do 4 sites, the distal wrist, the proximal distal leg, and then the foot. And we look for evidence of a neuropathy. So if I see a gradient between this site and the foot, then I'll suggest that that looks like a neuropathy, where you would have a distal loss of function, but more proximal retained function. The sweat test, where you cover the person in a dye and then have them go in a hot chamber and they sweat, and you observe the changes, and where they don't sweat, it doesn't turn purple, and where they do sweat, it turns purple. That's visually far more satisfying as a test. You can see this is a distal neuropathy, such as a diabetic neuropathy. This is someone with multiple system atrophy and no sweat response. I don't do that test. Way too complicated. Most kids wouldn't go for it. So now on to management. These items reflect the mainstay of management. I'm going to talk about most of them separately in subsequent slides. But as I was saying earlier, many persons with POTS start with this inciting event, whether they're a susceptible individual, they had a concussion, or had an infection, or they had some pain disorder, headache disorder, or some enforced bed rest. The combination of that susceptible individual, and those exposures lead to the development of symptoms. What we need to avoid is this cascade of diminished activity, further bed rest, leading to further deconditioning, leading to further worsening of symptoms, and this vicious cycle. Because this is the cycle that most of my patients come to me in, and getting them out of this cycle is the big challenge. All of that leads to the same outcome, that is this increased sympathetic drive. So the key things that we focus on for management are fluids and salt, exercise, compression, some degree diet, definitely talk about sleep, talk a lot about brain health, as well as pharmacologic management. So I'll talk about each of those separately. This is a nice cartoon of the main things that we spend time talking about with every patient. We talk about avoiding things that exacerbate symptoms, such as heat, large, heavy meals. Of course, the adolescents should avoid red wine, but the parents can take all they like. Liberal intake of salt and water, raising the head of the bed, compression, which I'll show you a bit more data behind that later. Physical countermaneuvers, such as simply crossing your legs or squatting, can relieve symptoms. Drinking water first thing in the morning. I was really happy to see this in this fairly recent review, because I've been recommending that for some time, and I really think that makes a difference. If you can get some water in before school, half a liter to a liter, that often sets them up for a much better day. And then a graded exercise program, and these are some examples of exercises that take gravity out of the picture. So swimming, seated rower, or recumbent bike. So that's the mainstay and most commonly recommended approaches to conservative management. Does salt help? And the answer here is absolutely yes, demonstrating that an increase in salt intake leads to a reduction in norepinephrine spillover, an increase in intravascular volume, and significant decrease in standing heart rate. Typical salt recommendations are 3 to 6 grams a day. In adults, we talk about 5 to 10 grams a day. Achieving 3 grams a day is fairly easy simply by not avoiding salt. Achieving 10 grams a day usually takes a concerted effort, as well as quite often supplementation such as salt tabs. So salting your food, eating salty foods, usually will get you to 4 to 5 grams quite readily. Pushing it to 10 grams and higher usually takes supplementation. Compression actually works, and whole leg compression and abdominal compression work better than lower leg compression. So this is just some data demonstrating the utility of compression. The problem with compression is you have to wear it. And most adolescents who I prescribe compression to talk about it working, but they never wear it. Because it's itchy, it's hot, it's not cool, it's whatever. And so that's a challenge we have with compression. So quite often I will recommend sport grade compression as opposed to medical grade compression, simply because they're more likely to wear an underarm garment than they are something that looks like, the grandmother's pantyhose. Now, short-term exercise is a critical and very important contribution to any management of any of these patients, and the evidence for this is significant. There are many approaches to this, but nonetheless, to say that a mix of aerobic activity 2 to 3 times a week and strength training, particularly for the lower extremities, and this is the FU study, used that combination and compared that combination over 3 months to propranolol and found that it worked as good as propranolol in treating the symptoms of POTS. But it also, of course, many other potential benefits, which I won't have time to get into, but certainly fitness and mental health. These are some body exercises that may contribute to lower body strength that I often recommend, and just for reference here, but you don't need to go to the gym. And that's a critical part. If you're going to exercise 4 or 5 times a week, going to the gym is not usually realistic, and seeing a physiotherapist every time is not usually realistic. They have to learn to do these things at home, and they have to learn to do them in many cases without equipment. So these are just some examples that can be done without equipment, strengthening the lower extremities. There are many approaches to drug treatment, and I list them here. And I think there is an opportunity to make informed choices about first-line treatment in these patients based on what type of POTS you think they have. So I outlined beta blockade, increasing intravascular volume using fludrocortisone, a vasopressor like midodrine, and then much more commonly, I'll make an effort to try to address the cognitive symptoms and fatigue using modafinil. So this is a table illustrating some of the individualized choices that can be made depending on what type of POTS you think you're treating, whether it be hyperadrenergic or volume dysregulation or neuropathic. And again, this is where the formal autonomic testing can be of some value in helping guide management, in that more likely than not to suggest that it's more likely to be hyperadrenergic or neuropathic based on the testing. And based on that information, some of the choices can be made. But beta blockade, not surprisingly, is something to consider more in those with hyperadrenergic POTS, but as can ababardine and pyridostigmine, acetylcholinesterase blocker, which increases acetylcholine levels. And in those who have more centrally mediated symptoms, clonidine is something I will use quite often, particularly if I observe orthostatic hypertension, which is something that can be seen in hyperadrenergic POTS. So their blood pressure actually goes up with orthostasis, not down. These are patients you would want to avoid SSRIs, SNRIs, or any NRIs, as that might exacerbate their symptoms. And then this group often has mast cell activation problems. In the volume group, a focus on oral rehydration or intravenous rehydration seems to have a greater impact. And then using fludrocortisone to reinforce that oral rehydration by causing the kidney to retain salt and water. This group may also respond to midodrine, and some treatments that I use less often include desmopressin. One important note is just to look if they are on an OCP, that drospirenone has been shown to exacerbate symptoms in these patients. And something that I've just developing some comfort with is the use of low-dose naltrexone in these patients. Finally, the neuropathic group, I start with midodrine and will often go to pyridostigmine next. I won't have time to talk about the autoimmune mechanisms, but this is of increasing interest. These are probably the patients that end up referred to me, and we don't have good guidelines to decide who would benefit from treatment and who does or does not have an autoimmune mechanism. But corticosteroids, IVIG, and other second-line agents have all been used, and the public interest in these is increasing. And then finally, I talked about modafinil as a treatment for the fatigue or brain fog. So I'm coming up to time. So I was going to try to spend some time on headache. I won't, but I'm happy to share these slides. Managing headache in POTS does need some adaptation because the typical treatments for headache can exacerbate POTS, such as pyramate and amitriptyline in particular. So avoiding drugs is the first effort in persons with chronic headache. And then secondly, avoiding drugs that exacerbate symptoms of POTS, such as Botox or some of the newer CGRP receptor antagonists, is how I approach chronic headache in POTS. And this is just a listing of those drugs approved for the new CGRP drugs approved for treating migraine. And the ones in bold are those that are in clinical trials in kids, children and adolescents. And we're doing all three of these trials in Edmonton. So if you have any patients you'd like to refer for those, we'd be happy to receive them. So in summary, POTS is a heterogeneous disorder characterized by tachycardia and orthostatic intolerance, and has as its core physiologic underpinnings a change in cerebral blood flow, as well as autonomic dysregulation. We talked about cognitive impairment, fatigue, and other symptoms which are shared across many conditions. And so borrowing management strategies across these conditions is a strategy that can be used. And then finally, the management of POTS and comorbidities like migraine benefit from individualized decisions based on what type of POTS they have. All right, so I will stop sharing and...
Wow,
Yeah.
Dr. Riche, you covered a lot of information, and I really appreciate you going over the pathophysiology of what's going on, the research behind it, and all of the treatment pearls. It was very comprehensive, which is great news because unfortunately we're on a real time crunch today. I don't see any questions posted in Q&A or in the webinar chat, and we only have a few minutes left. So I am going to wrap us up because we have a hard stop at 10:30. I just wanted to make you guys aware that Child and Adolescent Psychiatry Grand Rounds, it's a self-approved group learning, Section 1, as defined by the maintenance of the certification program for the Royal College of Physicians and Surgeons, and it's also approved by the Family Physicians of Canada for main pro credits. And I know that we also have a survey that we'd like you to fill out. We, as a Grand Rounds committee, I can assure you, we go through all of your comments and all the feedback that we get on these talks, and we do our best to try to get relevant topics and speakers such as Dr. Riche. So please do take the last few minutes to fill in the survey. And yeah, thanks so much for your attention. Thank you, Dr. Riche, for your informative talk. And this is great. This is great to learn more about. This is really practical knowledge. I love that you start with the education of the patient, the comprehensive assessment, but even just the assessments we can do in our own areas, and then all of the pearls and the tips that you give to patients. I know I was taking screenshots of them. I know that this is recorded and the slides will be shared, but just empowering us to give that information directly to patients of what can they do, not just what they can't do, and that knowledge that if they stay in bed longer, things actually get worse instead of better. So getting them up and active is so important.
Yeah, no, it's you know, that and that empowerment is so important. I think the patients often reflect a degree of frustration in maybe a lack of acknowledging their symptoms. And you know, one of my aims is to sort of show that these symptoms are real. These symptoms are based in a physiologic basis. Our approach to management may look very psychological. I may be talking about exercise more than drugs, but you know, that empowerment to say, I need you to work with me, and I believe you, is sort of where if I can establish that, then there's a hope. The best case I had was a kid I started seeing. She came to me from Manitoba in a recumbent wheelchair. I thought, I'll never help this person. She's in a recumbent
Wow.
wheelchair. She never sits up. How am I going to help this person? 2 years plus later, I followed up with her. She's now an adult. She said, Dr. Risch, I just wanted to call you. I'm currently in Spain teaching English. I just walked up the hill to take this call to get better reception. And
Wow.
I was nearly in tears because I thought,
I bet.
if you can help a person like this, and whatever we used, I don't even know in the end what helped, but it was that iterative process of taking them seriously and then working with them that made a difference. So thank you for all that you do, and thank you to everyone for listening.
Thanks, everyone. Have a great day.